Good morning, everyone. Today I'll be presenting on the workup of diplopia. What is diplopia? It is a simultaneous perception of two images of a single object that may be displayed horizontally, vertically, or obliquely. So, what is important in critical history taking? So, first and foremost step in the workup of diplopia is to differentiate monoocular diplopia from the binocular diplopia. So, we will ask the patient, does the double vision resolves on closing either eye? And it is important to note that we should not ask the patient that does the double vision goes on closing with one eye, because if the patient happens to close the affected eye, then the monoocular diplopia may be misdiagnosed as binocular diplopia. So monoocular diplopia, the most important causes are the ocular causes, whereas in binocular diplopia, it indicates ocular misalignment as a major cause. So we should dig deeper into the history for binocular diplopia. We should ask for image separation, whether the images are separated horizontally or vertically. If the images are separated horizontally, then horizontal movers are involved and the nerve supplying them. If it is worse with distance, then it is sixth nerve palsy, and if it is worst with near, then it is medial rectus palsy. Also, we should ask for worst gaze is equal to the action of the parietic muscle. But in case of muscle restriction, it is opposite. We should ask for any neurological symptoms, clinical course, and history of congenital strabismus or any corrective head posture. So examining a diplopic patient, we should look for visual acuity. On inspection, certain points should be noted. That is the corrective head posture the patient adopts to minimize the diplopia. Like turn to the affected side is seen in sixth nerve palsy, whereas associated ptosis can be seen in third nerve palsy, myasthenia gravis, or Horner syndrome. So pupillary examination is important. We should look for an isochoria. Mydriasis, more prominent in light, is seen in third nerve palsy, whereas meiosis, more prominent in dark, seen in Horner syndrome. In context of diplopia, it signifies cavernous sinus lesion. So the most important part of the diplopia assessment is extraocular motility. So if the motility is limited, then we should check whether it is paralytic or restrictive. That we will do by force reduction test. So if it is restrictive, it signifies orbital disease like thyroid eye disease or any Brown syndrome. If it is paralytic, then it signifies cranial nerve palsy. So if there is abduction limitation, that is seen in sixth nerve palsy. If the adduction is limited, either medial rectus is involved or there can be internuclear ophthalmoplegia, that is the damage to the medial longitudinal fasciculus, in which the convergence is paired. Elevation and depression can be affected in third nerve palsy, and also depression is affected in fourth nerve palsy too. But if the EOM is full and free, we should not stop. We should test for tropias and phorias by the various battery of tests, that is the cover test, Maddox-Raw test, Hirschberg test, prism bar cover test, to quantify the deviation. So if it is comitant, both for EXO and EXO and associated with AV patterns, it signifies infantile strabismus. But if EXO is present only at near, then it indicates convergence insufficiency, but only at far, then it indicates divergence insufficiency. Hyperopic esotropia is seen in accommodative esotropia. Whereas if the deviation is not equal in all the 9 positions of gaze, then it is incomitant and it signifies nerve palsy. EXO, same. If the convergence is paired, then it is internuclear ophthalmoplegia. But if it is associated with ptosis, mydriasis, and reversing hypertropia, then it indicates third nerve palsy. For esotropia in horizontal plane, it indicates sixth nerve palsy. Coming on to the vertical deviation, if there is hyperdeviation with comitant, which is comitant, then it can be congenital, or if it improves in supine position, then it is a skew deviation. For incomitant, reversing hypertropia is seen in third nerve palsy. If it is worse in adduction and elevation, then it is inferior oblique overaction. If it is worse in adduction and depression, then it is fourth nerve palsy. And in chronic cases, we can see both bilateral inferior oblique overaction with the fourth nerve palsy. If each eye is hyper in abduction, it is alternating skew, and if each eye is hyper in adduction, it can be bilateral fourth nerve palsy with inferior oblique overaction. So the structure is clear. First, differentiate monoocular versus binocular. In binocular, if there is limited extraocular motility, we will see for paralytic and restrictive, and for if the extraocular movements are full and free, then we should look for strabismus or any neurological cause. Thank you.
Thank you for that powerful lecture.
I think teacher is very clear about the concepts where the students are confused.
Just as usual with cases of squint, right? We are always confused. We need a repeat class of this. Okay, anyone from team Adesians, prepare your lecture there. In the meantime, judges may ask you. Team Adesian, yeah? One of you have to present, come here and inform the AV team which part you are presenting. So what was the source of all your this flow chart or this thing, from some books or what?
Sir, I have read articles.
All are this from
Yes,
article?
all
Okay.
the articles about workup
That's
of
good
diplopia.
because the aim of this teachers of tomorrow, to make you people go through what a teacher go through when preparing for a lecture,
Yes, I
right?
made a flowchart on by reading articles.
आ जाओ जल्दी.
Uniocular diplopia.
Sir, uniocular diplopia can be both bilateral or uniocular diplopia.
What is uniocular diplopia? You can
मतलब
say.
it is equivalent to monoocular diplopia. हाँ.
Can it happen?
Yes.
What condition?
Sir, in cortical lesions, rarely it can happen.
No, think something else.
Sir, in any like tear film abnormalities. Occur. Yes.
Ectopyrelentis, keratoconus, early cataract, these are all causes of monocular
Monocular
diplopia.
diplopia.
Okay.
These topics given to them or they have chosen themselves?
We have given them, sir, 1 month before, so that they can prepare the lecture and take the class.
One month.
Yes.